Now I call upon Dr. Veena Acharya.
So the topic I'm going to take about is monitoring and treatment of an anemic fetus. So we'll be looking at what's fetal anemia, what are the causes, the diagnosis, how do we monitor and how do we treat. So fetal anemia, I'll not go into the details because all these values that are mentioned here actually essentially need you to know the hemoglobin of the baby. A hematocrit below 30%. Again, we need to know the hemoglobin, and this is academic. It has no clinical relevance because we're not going to know the hemoglobin because we're not going to do a chordocentesis to check the anemic status. So there are various ways to identify anemia, but clinically we do it with ultrasound by a non-invasive method, as we will see in the latter part of the talk. Let's come to the causes of anemia, which are very important. So fetal anemia can be either immune anemia. Do you have a pointer? So it's immune anemia, which is the most common one that you see, which is due to a RBC alloimmunization, which is most often a RH isoimmunization. But we should not forget there are other antigens on the RBC which can give rise to this condition, like KEL, Duffy, KID, C, and E. Now, if you have ruled out that it is not an immune cause, then it can be non-immune. And this is important because although it can be rare, but that mother, it will be devastating to have sometimes anemic fetus of no cause or anemic fetus which is recurrently being recurrently having a similar problem. So what are the conditions here? One is it could be infections, and the most common one is parvovirus B19, and of course toxoplasma CMV can also give rise to anemia in the fetus. And second is feto-maternal hemorrhage. Sometimes there's no obvious hemorrhage, but this hemorrhage happening, which can give rise to a problem even in an Rh positive mother. So you've got to think of all these conditions when the mother is Rh positive and then still having a hydrops or a anemia in the fetus. Then placental causes, like in a monochorionic placenta, when there is small anastomosis between the two twins, which can cause a slow leak of blood from one to the other, it gives rise to a condition called twin anemia polycythemia sequence, again presents as an anemic fetus. Then you can have placental abnormalities like chorioangiomas or fetal tumors like sacrococcygeal teratoma, because it's a hyperdynamic circulation and then gives rise to anemia in the fetus. Then, although much rarer, these are more painful, the hereditary or the genetic causes, which can give rise to recurrent anemia and recurrent hydrops and fetal losses, like alpha thalassemia, black fun diamond anemia, Fanconi's anemia, lysosomal storage disorders, and many such. So it's important to know where our baby fits in. So whenever we have a baby with anemia, how do we go about doing the maternal evaluation? As obstetricians, what are you going to do? You do need to take a detailed family and a pregnancy history. About the pregnancy, have there been any incidences which can give rise to a isoimmunization in the present or in the past pregnancy? Has she not had a good enough prophylaxis? Has she missed telling you that she had had a medical abortion on her own, took an over-the-counter pill, and then she did not take because she wasn't aware she needs to take it? And many such things can give rise to a isoimmunized status. And of course, consanguinity, because genetic syndromes, the ones I mentioned earlier, which can lead to anemia. Has there been an infection exposure, like a parvovirus or a toxo or CMV? Has there been an abdominal trauma, which can again give rise to a fetal-maternal hemorrhage and then lead to fetal anemia? So that, apart from the history, we need to look at her blood pictures like CBC blood group and antibody screen. I'd stop a moment to stress upon antibody screen, and this is something we probably need to offer to all our women, because we are here talking about not only the Rh antigen, but all the others, the Kelly and the KEL and the Duffy and the KID, because the labs which do it will do it as a panel. So all the antigens are tested for, and if you find any of the others also positive, then you have an opportunity to monitor this woman and to prevent the onset of anemia or treat if it happens. And if it's positive, then do a titers as well. Do a hemoglobin electrophoresis can give you an idea about alpha thalassemia carrier state, because there's no alpha thalassemia living people. You can do a Clay-Hauer-Betke if there's a suspicion of a feto-maternal hemorrhage. You can do a serology like for a parvovirus, CMV, IgG toxo, etc. So And coming to the commonest cause, which is RBC alloimmunization due to RH, which is the commonest cause, and this is either due to an inadequate dosing or a missed prophylaxis for a sensitizing event. It could be an unrecognized fetal-maternal hemorrhage or a poor patient compliance to take this prophylaxis, or as absence of prophylaxis for the other RBC antigens that I mentioned. So, which are the pregnancies at risk when they come to you? First is if she's had a previous history of a hemolytic disease in the previous pregnancy. She's had a high drop, she's negative and the husband's positive, and she's lost the baby. You got to start monitoring her for anemia at least 10 weeks before the timing of onset of or timing of mishap in the previous pregnancy. So that's important history. Or you've done a good routine maternal screening and you have found antibodies in her, okay, and then you need to, these pregnancies are at risk of developing fetal anemia. And so they need closer follow-up. And if you have found an RH isoimmunized pregnancy, you've done an indirect Coombs test and it's positive, what do? You got to know the titers of the antibody, monitor them serially every 4 weeks till 28 weeks and every 2 weeks thereafter. And the critical levels are 1 in 32 in most laboratories, because until then the risk of developing anemia or hydrops is low. So once a critical level is reached, you monitor them MCA by the middle cerebral artery peak systolic velocity weekly to then time the treatment as to when you need to intervene and do a therapy. So MCA Doppler velocimetry is done, and if it is less than 1.5 multiples of median, you just keep following it up weekly, and if it is above that, then you need to do a plan for a fetal blood sampling and a fetal blood transfusion. And MCA Dopplers are less reliable later on in pregnancy after 36 weeks, but of course by 36 weeks you have cooled off and you can even induce and deliver her. So when you do an ultrasound, how do you assess the fetal anemia? I told you, now it is non-invasive ways are available, and the Doppler measurement of the peak systolic velocity in the MCA is the gold standard. And if this is increased more than 1.5 multiples of median, this is the diagnostic of anemia. And just using this method, you can diagnose almost all the babies who are isoimmunized, non-hydropic, and anemia can be diagnosed moderate to severe anemia with a false positive rate of only about 10%. The other features could be high drops. If you've developed, especially ascites is much more common, placentomegaly, hepatomegaly, splenomegaly, and similar Doppler's abnormality can be there in aorta and splenic artery, but they're not seen as often. If there is anemia and there is no RH isoimmunization, you can look for other anomalies like a sacrococcygeal teratoma, or is there a hemangioma, and look for signs of infection in the baby like a ventriculomegaly or a hyperechogenic bowel or a growth restriction. And why do we talk about MCA Doppler? That's because whenever there is a fetal anemia, there is an increased cardiac output, there's a reduced peripheral resistance and a decreased blood viscosity altogether, which increase the flow, velocity of flow in the arteries. And the MCA has the most reproducible measurements and the least inter and intra-observer variations, and that's why that is used as the standard for assessing for fetal anemia. So how do you assess if you're doing it? Okay, so that's a well-zoomed picture of the baby's head in the BPD plane. A little below the BPD plane, you will find the circle of Willis, and you put on the color Doppler, and you will find the MCA arising from the internal carotid artery there, and then you put the gate across the MCA. I'm going to play. Yeah, and then take a waveform, 3 to. Is using it? It's not playing. Yeah, okay. So 3 to 4 waveforms, and the maximum velocity obtained should be taken. And then it is plotted on a chart. It's important for us to know because there's no one definite cutoff for a given gestational age. The MCA PSV, the red line which shows 1.5 multiples of median, increases with advancing age. And so you chart it and you know that this baby is anemic and would require intervention. So then what do? You plan for a transfusion, and at that time you take a fetal blood sample by cordocentesis, and you should do various tests to know the blood type, what's the counts, direct Coombs test, the reticulocyte count and the bilirubin. You can also do a PCR, or a polymerase chain reaction test, to look for any infections in the baby, and you also can do genetic studies. And blood transfusion, as we know, it's one of the most successful fetal therapeutic procedures because it intervenes here. When there's severe anemia, progressively lead to hydrops and then death, and that can be corrected. Of course, there are no randomized trials because the benefit is too good to have one arm where we are not going to be treating these babies. So it is beyond doubt, it's been proven to be a very effective therapy. And the fetal anemia causes the polyuria, polyhydramnios, reduced fetal movements, fetal hydrops, and ultimately death. And timely intervention can save these lives. 97% in expert hands have shown survival in a RH isominase baby. The techniques of, I thought it was 15, intrauterine transfusions are intraperitoneal, intravascular, either by chordocentesis or intrahepatic route, and even by cardiocentesis, and we could use a combined approach as well. And when do you do it? It's usually between 18 and 35 weeks. Beyond 35 weeks you deliver, before 18 weeks it's a little difficult to do. And when the fetal MCA-PSV is higher, you do a chordocentesis, establish the hemoglobin, and do the transfusion. So what do you need to get? This is extremely important. You transfuse with fresh, irradiated, leuco-depleted CMV and HIV negative packed cells. With they're highly packed, the hematocrit is 70 to 80%, and you calculate the volume, and after consent, do the transfusion. And there need to be good blood banks to give you this kind, because it takes about 8 hours to prepare a blood unit after doing all this process. So you need to calculate. There are various methods of to calculate, but it's easier, simpler to use a software wherein it will give the baby's weight, what's the pre-transfusion hemoglobin, what's the donor hemoglobin, and it will give you the amount of volume that you need to transfuse. You can use fetal paralysis either with atracurium or vecuranium, which can be either intramuscular or intravenous, because movement can hinder or it can cause complications when you're placing a needle there. You have to prepare the mother. If it's more than 26 weeks, doctor has just now told you that might be the viable period. You give antenatal steroids, antibiotic, and local anesthetic. And if she's very anxious, you could consider midazolam. In our practice, we hardly need it. Just have a good talk with her, and that will work. So that's a video showing, we have measured, we know that it is anemic, and then you go ahead and locate the placental cord insertion. So when we talk about cord insertion, it has to be the placental cord insertion. Under complete ultrasound guidance, you have to identify the umbilical vein and insert the needle. I'll take 2 more minutes, doctor, please. And do the transfusion, and under continuous guidance. It could also be done intrahepatically. Here we are doing anesthetizing with the thigh. Into the thigh, we are giving a anesthetic drug, and then we do the intrahepatic venous, sorry, I can't go forward. Yeah. You take the umbilical vein and then do the transfusion. It's a longer video, I'm not going to play for you. And it can be intraperitoneal. This is very early, where you have, it's less than 18 weeks. It's intraperitoneal is another method. You can also do combined IVT and IPT, whereas you do some amount intravenous, some amount intraperitoneal, which acts as a reservoir. So the fall in the hemoglobin will be slower, so the next transfusion can be later. Even intracardiac has been done. So subsequent transfusions, it is based on the rate of fall. It's about 1% per day after the first transfusion, and with increasing number of transfusions, the fall slows down, because all the erythropoiesis gets suppressed, and all the fetal blood cells are now.
Can we interrupt?
Yeah.
I think we are falling short of. There is a plenary session to follow.
Sure. Yeah.
Hard pressed with the time.
Okay.
Right.
So the complications, I leave that out. Okay. And in summary, it's important to have routine anti-D prophylaxis to all your pregnant women, and anti-D after every sensitizing event, and a complete antibody screening for everybody, all the pregnant women. And you do ICTs and repeat them, and if it's positive, a quantitative analysis of the Rh antibodies, and refer early for a MCA Doppler and a blood therapy. And if it's other causes, which is parvovirus, you have to monitor MCA-PSV for 12 weeks after seroconversion. Genetic cause, investigate the couple, and we can do a prenatal diagnosis in the future pregnancies. Placental cause or sacrococcygeal teratoma, both have treatment with the laser ablation. Thank you very much.